Our next speaker is Marianna Hensley, who's joining us from New Delhi. And Marianna, you are here in front of a group of, I don't know, 24 or 30 faculty and students and others at Villanova. And I think we can hear you, so the floor is yours.
Okay, thanks, Steve. Again, let me introduce myself. Oh, can you hear me?
Yes. Yes.
Okay, great. My name is Marianna Hensley, and as Steve said, I'm based in New Delhi in India. I currently work with CRS as the Regional Technical Advisor for Monitoring and Evaluation, Accountability and Learning in East and South Asia. But prior to that, I worked with CRS in India as their Health Program Manager, and in that role, I led the project design and mobile content development for the Reducing Maternal and Newborn Deaths project, which is otherwise known as the REMIND project. So for the next few minutes, I'd like to speak in general terms about how CRS is using ICT for global health. And specifically, I'd like to share with you a case study of the REMIND project. So Steve, can you advance the slide, please? Okay, so here is our agenda. In terms of the REMIND case study, I'll share with you two ICT innovations that have been used in that project. The first is the use of mobile job aids with community health workers, and the second is leveraging mobile technology for supportive supervision of health workers. And I'll close out the session with lessons learned, and hopefully there'll be some time to take some questions if you have any. Next slide, please. Okay, so the REMIND project is a 4-year initiative that's funded by Catholic Relief Services with some additional funding support from USAID's Div2 fund. CRS partners with technology innovator Dimagi, and our local implementing partner is Vatsalya, and we also work in close collaboration with the government's National Health Mission to implement the project. REMIND is implemented in Kaushambi district in the Indian state of Uttar Pradesh, or UP. UP is the largest state in India, so to put that in perspective, 1 out of every 35 people on the planet lives in the state of Uttar Pradesh. So just digest that number for a minute. And couple that with the fact that UP has the highest rate of maternal and newborn death in all of India. And what that means is you either have a public health dream or a public health nightmare, depending on your point of view. But with such a large population and such a high rate of maternal and newborn death, it means that if we can make a difference in maternal and newborn death in Uttar Pradesh, we can literally make a difference in the world. So that's very compelling from a public health point of view. So in late 2010, early 2011, when CRS began project design for what was to become the REMIND project, we started looking at where could we work to try to contribute to improvements in maternal and newborn survival in Uttar Pradesh. And we decided to focus on leveraging the government of India's existing network of community health workers called ASHAs. And in the image you see on the screen, the lady on the right is an ASHA. These are rural women with limited levels of education, but they're chosen by their communities to serve as community health workers. The government had done an evaluation of the health worker program, and they identified 2 major barriers to community health workers' effectiveness. One was poor quality training, and the other was the virtual absence of supportive supervision. And so as CRS was doing project design, we tried to consider how mobile technology could be leveraged to address these 2 barriers and essentially improve the quality of community health workers' home visits. So REMIND is currently working with 259 government community health workers to improve the quality of their home visits to pregnant and postpartum women and young children. The community health workers that we work with use basic mobile phones. So on the slide, you see that little Nokia Java phone that that we're not high tech in the Remind project. This is a very basic Nokia phone that operates Demagi's open source ComCare software. And that software equips the health workers with multimedia job aids. What that means is the software has a combination of still images and audio that as the health worker navigates through the application, both she and the woman she's counseling, so in the image the pregnant woman is on the left, can see images and hear in Hindi counseling messages. And this job aid helps the ASHA to systematically assess and counsel her clients. It also helps her with the early identification, treatment, or rapid referral of both maternal and newborn complications. The mobile job aid that we use also helps community health workers to promote childhood immunization through mobilizing and counseling families, as well as tracking immunization status of young children. So this maternal, newborn, and child health application is the first of Remind's technology innovations. Can you advance the slide, Steve? So the next, hopefully you now see a little green man with binoculars. The Remind team realized that community health work, that supervising community health workers was an integral part of managing the structure required to support the CHW's use of mobile technology. And we had already learned from the national evaluation of the health worker program that the health workers need supervisors. Now, the government already had plans to put in place a new cadre of CHW supervisors called ASHA facilitators. But at the time the Remind project was deploying the maternal, newborn, and child health application, this government cadre of supervisors had not yet been put in place. So as a precursor to the government's rollout of the ASHA facilitators in Uttar Pradesh, and with the full cooperation of local health authorities, the Remind project operationalized a model of project-supported supervisors to provide supportive supervision to the health workers in the project area. Now, the purpose of this was to test and refine operational approaches and to identify lessons learned and contribute recommendations to the government so that they could feed it into their eventual rollout of ASHA facilitators across the state of Uttar Pradesh. Now, the project took the national level model for health work supervision one step further by equipping supervisors with an ICT 4D enabled supportive supervision tool that used the same ComCare platform on the same basic Nokia phone that the community health workers were using. So this supportive supervision application was Remind's second technology innovation. Can you advance the slide once more?
I think we were one ahead of you.
Okay.
We're in the right place.
Oops. Okay, it should still be the Remind project slide with the arrow going to the handbook for ASHA facilitators.
Yes.
Okay, so where the project is now, the government has in the last 1 or 2 months finally put in place their own cadre of ASHA facilitators or ASHA health worker supervisors, and the government asked the support from the Remind project team to equip these new health worker supervisors with a mobile supportive supervision tool. So that's those are the two innovations in the Remind project. Now, Steve, can you go to the next slide, please? I'd like to talk you through the workflow for the community health workers mobile application. So the way it works is the community health worker registers a pregnant woman using the basic mobile phone, and then through the course of the pregnancy, the health worker conducts a series of home visits when she counsels the pregnant woman. She assesses whether she's been attending antenatal care, if she's had her tetanus vaccinations, if she's taking iron folic acid. During those visits, the mobile tool also helps the community health worker to systematically assess the woman in terms of whether or not she's experiencing any danger signs. If a danger sign is detected, the application prompts the health worker to refer the woman to a health facility for treatment. Then at delivery, can you advance to the next slide, please? So at the time of the delivery, the yellow boxes represent the mother's case. The green box is the baby case. So after the woman gives birth, the community health worker, according to the government protocol, conducts a series of postpartum home visits during the first 42 days of life. And during that time, in each visit, there's a head-to-toe assessment of both mom and baby to look for any maternal or newborn danger signs. If a danger sign is detected, there are two options depending on the danger signs. All maternal complications are immediately referred to facilities. Health workers have now been trained to do community-based management of neonatal sepsis with oral cotrimoxazole. So the app walks the health worker through the algorithm for IMNCI. At the end of the 42-day period, the mother's case closes in the mobile application. And can you go to the next slide, please, Steve? The baby case continues to remain open in the health worker's phone. So for the first 2 years of life, or from 0 to 23 months of age, the health worker then continues to track the immunization status of the child, and she also has a series of counseling material around routine immunization that she can use with family members. So if we can advance the slide once more. Now you see the full workflow for the maternal, newborn, and child health application that's used by the community health workers. I would draw your attention to the gray boxes at the bottom of the slide, where you can see in the pregnancy, postpartum, and then the 0 to 23 month period, the different pieces of data that are captured through the health workers' use of the mobile application at each phase of case management. So I'll let you look at that for just a moment. Okay, next slide. The screenshots that you see on the next slide of the application summary, this is what shows up on the mobile phone that the health worker is using. So there are 5 different modules that the health worker can choose from. One for pregnant mothers, another for postpartum mothers, and then the baby module that tracks both newborns and young children, and a separate referral module. So you can see there an example of how the application uses still images along with written text, so that health workers, many of whom are low literate, can use the combination of seeing both the images, and unfortunately I can't play the audio for you, but they can click on a button and know what's written in Hindi, how they see that. I'd like to share a bit of data with you. Can you go to the next slide, please, Steve? So in terms of coverage, again, to date, this application is being used by 259 community health workers across 2 counties in the district of Kaushambi in Uttar Pradesh. And since August of 2012, mobile empowered health workers have supported more than 16,900 women and more than 13,900 children under 2 years of age in the project area. Those were the figures as of the end of August, so I'm sure we're over both 17,000 and 14,000 now in terms of number of women and children served. On the next slide, I have just a few of the preliminary results from the project's midterm evaluation. Home-based visits by health workers to pregnant women increased from 60% at baseline to 76% at midterm. Can you advance to the next bullet? We also found at midterm that there was an increase from 44% to 72% of women reporting that they had received counseling from a community health worker during their most recent pregnancy. Next bullet. The average number of counseling visits that a woman received increased from 1.18 to 1.95 after the introduction of Remind's MNCH application. Next bullet. At midterm, we found that the average woman in the project area received 45% more antenatal care checkups than at baseline. And last bullet, there was 58% more women received 3 or more ANC checkups at midterm as compared to baseline. So these are preliminary results, but we've found them very encouraging just in terms of the increase in coverage of community health workers' visits and the frequency of counseling, as well as the improvements in ANC. One of the questions that the evaluation team is currently trying to tease out is what was driving the change? How much of it was the health workers' use of the mobile tool, and how much of it was the result of the supportive supervision that the project put in place? Again, the analysis is still going on those results, but one thing that is clear is that the supportive supervision component is a key piece to the improvements that we see. So Steve, if you can advance to the next slide, this gives you an overview of the mobile application that is being used by health worker supervisors, and it works in much the same way as the maternal, newborn, and child health application, only whereas in the MNCH app, it's the pregnant woman who's the client. With this ASHA facilitator or supportive supervision app, it's the health worker who is the client. So the way the flow of the application works is the supervisor first registers the community health worker, and then the supervisor does routine, on average monthly, visits to the community health worker that are supported by the mobile ICT tool that helps her to track the health worker's level of functionality. Supervisors then receive an analysis of the ASHA's performance, and it's discussed in monthly health worker meetings, and that allows the supervisor to do two things. One is to identify low-performing community health workers and to provide targeted support to those who are underperforming, but the data from the application also allows the supervisors and the other local health authorities to look more broadly across all of the community health workers to identify priority needs for capacity strengthening. And this is the application that the government of Uttar Pradesh is now very interested in testing and potentially scaling to the rest of the state of Uttar Pradesh. So I'd like to close out with some lessons learned from the Remind project. So the first test, then deploy. I can't emphasize enough how important it is to plan sufficient time for field testing and application revision before deploying to a large number of users. Because once an application is deployed, it's much more challenging to introduce changes given the time and the financial costs of reinstalling and retraining users. Next bullet, it takes a team. So content development, mobile content development requires a wide variety of expertise. So sectoral expertise, tech expertise, you need really good translators, you need implementation expertise. So all of these things need to be taken into consideration as you put together the team that will be developing the mobile content for your application. Next bullet, there is a lure of real-time data that comes with mobile technology, and it can be very, very tempting to include lots of nice to know content in your mobile application, but what this leads to is user fatigue due to loss of interest because the content is so long or complicated. It can also lead sometimes to fraudulent data entry if the health worker just sits at her house to fill out the form. It also puts program managers or others at risk of not actually using all of the data that's generated through the mobile platform. So where mobile content includes data collection, be sure to focus only on the need to know information, and begin planning for how and when that data will be used at the time that you're developing content. Otherwise, you'll end up with a massive data set and you won't even know where to begin because it's so huge. Next bullet. Be willing to share. There is so much work going on globally in mHealth, and there have been lots of mistakes made along the way, but if we're willing to share what we learn with each other, it benefits everyone. So look for ways to share your content and lessons learned with other mHealth actors. Share applications with others that use the same or compatible software platforms, and try not to be proprietary when you're sharing your content or learning. It just everyone benefits if you're willing to share and learn and share. Next slide. So some specific lessons about scaling up mHealth interventions. With the Remind project, it was by intentionally aligning project management and supervision structures with what the government policy proposed for health worker supervision that put Remind in a unique position among the ICT4D actors in the state of Uttar Pradesh to bring operational lessons and recommendations to the state. So if you're planning a mobile health intervention that you're hoping would be scaled through the government, be sure that you align your content with the government's policies and guidelines. Next bullet. So Remind has two distinct technology innovations, as I already shared, the maternal, newborn, and child health application and the supportive supervision application. When the project team was assessing the different innovations for scale up, it was the supportive supervision app that has the greatest potential for scale. So while the project continues to work and gather evidence around the effectiveness of the community health workers app, advocacy and scale-up planning with the government is focused on supportive supervision work. But the two are not mutually exclusive, because a scaled-up ICT4D solution for supportive supervision of health workers would actually create the basis from which you could eventually scale a successful health worker application. Next bullet. When you're thinking of scaling up, don't underestimate the time and resources required and the absolute necessity of investing in documentation and evidence gathering to justify the case for scaling up an ICT4D solution. Likewise, the time required for advocacy with the government. Our team has spent hours and hours just sitting in government offices waiting for meetings. And that's a significant time commitment, and you might need to think about hiring dedicated staff just to cover the advocacy and representation side if you're looking to scale through government structures. And finally, last bullet, seek strategic partnerships and champions. No one organization can realistically scale up an ICT4D solution. So it's imperative to find the right partners who bring complementary skills and capacities to scale up efforts. Similarly, it's really important to cultivate champions at all levels of the health system in terms of promoting buy-in and long-term commitment for the innovation. So that means from the level of the community health worker supervisor up to government policymakers. Look for champions who can really push forward your innovation and promote its scaling up. Next slide. That is actually all I have for you. I think we've got maybe 5 minutes available for questions. So if there are any questions, I would be happy to take those now.
So the slides that were presented are very similar to what Marianna has presented. So there's a lot of similarity to the project we're doing in Nicaragua. Two questions I have. One is she described using open source software, and the second was using basic mobile phones. What about an alternative approach where you're using proprietary software and smartphones? Any comments related to that?
Marianna, are you able to hear the question, or do you need to repeat?
Yeah, I heard it. So first about open source, we chose to work with Dimagi using their open source ComCare software, and for us that's really, it's been a boon. because one, the software was originally designed with community health workers in mind, and with case management by community health workers. So that in itself made the software very, very appropriate for our case. But when we were developing the content, because it's open source and the content is shared, we didn't have to start with zero. We actually started with a pregnancy checklist that World Vision had developed for use with health workers in Afghanistan. And we took that and began recrafting it through a very long iteration process. And I'm sold on open source. I think it's great in terms. I think it facilitates knowledge sharing, and it allows for the more rapid sharing of innovations and lessons. In terms of basic phones versus smartphones, we at the time we launched, which would have been like we did our first large-scale deployment in August of 2012. One of the reasons we went with basic phones at that point was cost. They were less expensive, but also they're much sturdier than smartphones, and the battery life was much better. Other reasons that we chose basic mobile phones, when we were initially doing a mobile landscape analysis, so trying to understand the community health workers' mobile literacy, those of them, the health workers who had phones, were using like basic Java phones. So we decided to stick with that model because it was something that they were already more familiar with. Another challenge, we work in a very rural area, and there are no local service providers who could do maintenance on smartphones. So if a phone broke, it would have to be shipped out to the closest city for maintenance, which wasn't practical.
I should add, Marianna, before you joined, we had some questions earlier about open source versus commercial. But Demagi has worked quite well for us in this space because Demagi makes their software available for free, and their business model is the services that help you implement that, and it's that combination that's worked very well for us. And I think there's sort of good analogies like Red Hat Linux, that it's a free piece of software, but they're packaging it in a way with services that allow you to provide the support and maintenance.
I have a comment.
Exactly, and just to say, Demagi has been a fabulous partner for us, and both their remote technical support and their in-person support has been phenomenal. I highly recommend them.
Great. So the reason I asked the question is that we're using the same philosophical approach, and also the same approach is being used by UNICEF. On the other hand, in Nicaragua, we were working, there's a parallel program called the Mesoamerica program that's funded by the Gates Foundation, the Carlos Slim Salud Foundation, and they're working with smartphones and proprietary software, and it's just, very heavily funded, different approach. I think that our approach is really the one that's more implementable, and I have the same endorsement from UNICEF, and it sounds like what you're advocating is a similar approach as well.
There was a document that came out recently from a number of agencies, there are parts of the UN and major private foundations that talks about the principles of using technology in relief and development. And one of the points that it makes is around open data and open standards. And I think that's really to me kind of the ultimate answer to say, be able to choose the software that you want and the devices that you want, as long as the data is interchangeable and is shared in a format that lends itself to sharing. Thank you.
Steve, we have another question.
I was wondering if and she may have said this, but I might have missed it, is the data that's being collected on each of the community members then transmitted into some sort of electronic health record so that they're able to follow them and keep those data available for future use?
I didn't hear all of that question.
So the question is the data that's being collected collected by each of the community health workers, is that aggregated and able to share?
Is it in an electronic
Is it
health
in-
record?
Right, is in the electronic health record.
It's not an electronic health record in the sense that nurses at health centers or doctors at the hospital can access it. At this point, it's more of the aggregate data that's being accessed by the local health management team for broader management decisions as opposed to individual case management beyond the level of the community health worker.
Okay, thank you.
Aside from the community health
And
workers,
one of the reasons for that is that the community health workers that we were working with, except now for the addition of community case management and neonatal sepsis, they don't actually provide services. Their function is more for counseling and mobilization. So it's the auxiliary nurse midwives who are providing antenatal care and providing immunization services, and the midwives are the ones who, if they were an electronic health record, it would be more appropriate at their level as opposed to the community health worker level that we're engaged with.
Okay, we'll take one more short question.
aside from community health workers, are there any local partners that you work with? I'm thinking of local healthcare clinics or traditional midwives. What role do they play in the services you provide?
So the question was, aside from the community health workers, are there other local organizations that we're working with, such as midwives and others, and what role do they play?
In terms of the use of mobile technology or in terms of broader health programming?
Both, actually.
Both.
Okay, with mobile technology, it's the community health workers and the government's health worker supervisors. Those are the two crowd that we're working with in terms of ICT. There has been engagement with the auxiliary nurse midwives and with the county and district level health management teams to help with coordination of community-based service delivery.
Well, Marianna, this is Sue Toten. I just want to thank you very, very much for your excellent presentation, and I also appreciate your invitation to contact you and set up a conference call with some of the nursing faculty who might be interested in follow-up on this. But please join me in thanking Marianna, and especially
Thank you very much.
thanks for being with us.
Thank you.
Good, we did well. All right, we'll take just a 2-minute break. Sean Ferris is next up, and he's going to be talking about business applications. So if you want to grab a